Good evening, everyone. I think it is very nice to see everyone around. With blessings of our President, Dr. Toprani sir, and Dr. Arvind sir, our Secretary, this is the eighth webinar which we are having, which has now become a monthly affair with around 250 to 300 people joining. So today we'll have a multidisciplinary discussion on esophageal cancers. I'd like to request Dr. Toprani sir, our President, to say a few words. Over to you, sir.
I am happy to see the progress of our webinars, the way we are getting feedbacks. Many people are joining, as Suman said, at least 250 to 300 people every webinar. And we are selecting topics which are of interest to all the specialties. And that is how the multidisciplinary tumor boards work. So without wasting much time, I would give it over to Samir to set up the meeting today.
Thank you, sir. So esophageal cancers, especially when we talk about in terms of Indian context, most of the cancers, esophageal cancers, we deal with are squamous cell, but the incidence of adenocarcinoma is also gradually increasing. And when we talk about adenocarcinomas, the long debate of CTRT versus peri-op chemo is now more or less settled, and now we all agree that yes, peri-op chemo is a better choice for junctional tumor adenocarcinomas. But for squamous cell, we still believe that there's a strong role of radiation in the management. Even the guidelines, they favor a lot. But yes, recently there are certain developments, there are new studies who favor chemotherapy over chemoradiation. And let's see. So basically, in today's session, we'll witness this debate of whether NACRT is better or NACT should be the standard of care in squamous cell esophageal cancers. So without wasting any more time, I would invite my debaters. First, I would invite Dr. T. Raja, Director of Department of Medical Oncology at Apollo Cancer Center, Chennai. The topic is NACT alone and not NACRT should be the standard of care for locally advanced esophageal squamous cell cancers, and he'll be speaking for the motion. Over to you, Dr. Raja.
Hey, sincere thanks, Dr. Samir, for inviting me, ISO, and the entire organizing committee, Dr. Toprani, Dr. Arvind. Thank you so much, and giving a very interesting topic. And as Dr. Samir said, why NACT alone should be the standard of care. So what is the rationale in any neoadjuvant therapy? As we all know, we look to reduce the micromets, and then if possible, we try to downstage the primary tumor. This would be for any site, and then possibly less morbid surgery. And then, of course, one other important thing about any neoadjuvant therapy is that at the end of it, we have a pathological assessment, and then we know based on the responses, how do we select the adjuvant therapy. In this setting, we have two options, neoadjuvant chemotherapy and neoadjuvant chemoradiation therapy. So the goals are, when we look at improved survival and then a better resectability, we also need to look at toxicity reduction and look at the complications and compliance when we want to choose the best between the two. So why should we question the pedestal of neoadjuvant chemoradiation? As Dr. Samir mentioned, up till now, it's still being considered as a standard of care option, but then we need to look at the complexity of delivery of radiation, toxicity, and cost. And is really radiation necessary when surgery is there for a local control, is the question that we are trying to ask. The neoadjuvant trials, particularly in esophagus, have looked at this premise: PCR can be converted into DFS or OS. That's the premise on which all these trials were mounted over the past 20 years. If you look at the trials, important ones, for the neoadjuvant CTRT, one definitely will have to talk about the CROSS and the URTC and the TROG and the IRIS study. And again, for neoadjuvant chemotherapy alone, again, there are many trials, including the intergroup 13 and the JCOC Japanese trials. And if you look at them more specifically, particularly in the context of squamous cell carcinoma, if you look at the EURTC trial, which was mounted in 1997, which was a pure squamous cell carcinoma trial, you see that the 5-year overall survival was no different between both the arms, whereas the PCR was slightly higher. But with regard to the trials that came later, TROG and the cross, what you immediately see is that the squamous cell carcinoma component was not the predominant one, particularly the cross trial, which is often quoted as the standard of care option. You see that the squamous cell carcinoma component was only 23% in the cross trial. That's very, very important takeaway we need to keep in mind. So what came out of the cross trial is that we saw that the median survival, overall survival, was better with the concurrent CTRT arm as compared to surgery alone. That's fine. But then remember that the squamous cell component was less than 25% at 23%. There was also a subgroup analysis on the squamous cell carcinoma component, but it was not originally powered, and the total number of patients on each arm was 175, and in that the squamous cell component was not powered enough to answer the question. But if you look at the neoadjuvant chemotherapy trial alone, once again, you see we'll just focus on the trials that had either a predominant squamous cell carcinoma or pure squamous cell carcinoma. In that, you have to consider the Japanese series of trial, which is a very important JCOC trial, a pure squamous cell carcinoma trial, and 9907. There are other Japanese trial. We'll address that in a minute. Now, we look at what is supporting the motion that neoadjuvant chemotherapy is probably the new standard of care. There are Japanese data. We're going to talk about it, the 9907 and 1109. And there is fortunately Indian data and then European data, and there is a meta-analysis, and we're going to look at this. The JCOG 9907 is the neoadjuvant followed by surgery. Again, surgery followed by adjuvant was the control arm. So the chemotherapy was delivered in both arms, fortunately, one in neoadjuvant and in the adjuvant. So whatever the change that is seen here as the neoadjuvant arm to be superior to the adjuvant arm, so the chemo, the delivery at neoadjuvant probably was the best when everything was pristine, when the vessels were good. And the neoadjuvant, the overall survival was better with the neoadjuvant approach, and the 5-year overall survival rate was 55%, more than 12% difference as compared to the adjuvant arm. And a more recent study that was presented in a couple of years ago in 2022 GA ASCO is the JCOG 1109 trial, another very important trial in which there is a 3-arm design in which neoadjuvant chemotherapy, neoadjuvant triplet chemotherapy, doublet chemotherapy, and then neoadjuvant doublet with radiation. So there is a lot of takeaway. This is a very contemporary, because you have a transthoracic asympectomy and then you have a regional lymphadenectomy. One can say that this is a very contemporary trial, because the previous cross trial, they were all designed at 10 years ago or 15 years ago in that domain, but this is very contemporary, and you will see the overall survival and the conclusions. Let me just come to the conclusion. Neoadjuvant triplet chemotherapy, but not the neoadjuvant chemo RT, significantly improved the overall survival over the neoadjuvant chemotherapy alone. So the most important takeaway is that the neoadjuvant chemotherapy is non-inferior to chemo radiation, and the triplet is better than the doublet, and the triplet is better than the chemo radiation arm. And they would recommend that the triplet should be the new standard of care. This is a network meta-analysis published by the European group. And again, what is seen is that there is no difference between the neoadjuvant chemotherapy and the CTRT arm with regard to the overall survival. So therefore, then it will bring us to the question, what is the toxicity trade-off? This is the Indian data from All India Institute of Medicine, and Vaibhav and group have led this one, while they say that the PCR rate is obviously better with the addition of radiation, but the recurrence rate and the overall survival were similar in both arms. This is again published just in 2023. So these are all the contemporary trials that would tell us the standard of care of the radiation and the modality of radiation was all contemporary. One can assume that IMRT and the most recent techniques were used, and therefore you can't take away the benefit of chemotherapy in this area with these contemporary trials. So in that context, we have to look at the toxicity and surgical complication. what is the trade-off from cross trial? We are looking at morbidity and even mortality, not only the treatment related mortality, but there are distant recurrences because the cross doesn't completely address the distant disease, as you all know, apart from all these chylothorax, pulmonary complications, so on and so forth. This is the Swedish group. You look at the morbidity and mortality. This is the NEORS trial in which both the neoadjuvant chemotherapy was compared with neoadjuvant chemoradiation. What you see is that the 90-day mortality, surgical complication, non-surgical complication, any complication, anastomotic leak were all very worse in the radiation included arm. The other perspective is that if you look at the Western data particularly, you would always see that radiation is preferred in the Western countries and in the Western guidelines. But if you move towards the East, Japan, Asia, where actually the esophagus disease is more, you would see the practice pattern is totally different, in which chemotherapy or neoadjuvant chemotherapy is considered probably as the standard of care. Another important data that I want to present here is that the NACRT Neo NESC trial, in which immunotherapy is added to chemotherapy. And this is why I would want to present this, is that this is the first randomized multicentric phase 3 trial of addition of immunotherapy along with chemotherapy in the neoadjuvant setting in pure squamous cell carcinoma in the esophagus. So this is a very important trial, and you would see that the primary endpoints are PCR, EF, and so on and so forth. So in the year last year ASCO 2024, some of the primary endpoints were presented, and the PCR rates were better with the addition of immunotherapy, and the esophagectomy rates were better, the response rate were better, and most of the the depth of the pathological response were better when immunotherapy was added to chemotherapy. So the takeaway is that the addition of immunotherapy has really changed up to the ante here. So I would conclude that neoadjuvant chemotherapy provides systemic control with less side effects as a trade-off. Neoadjuvant chemoradiation toxicity may not yield proportionate gains that we want. So we may have to reconsider the standard in favor of the neoadjuvant chemotherapy. And neoadjuvant chemoimmunotherapy may actually soon take over. And the conclusion of the next trial is that probably this will be a new standard of care. And so much so that in the esophagus, locally advanced disease, where we have surgery in sight, probably in squamous cell carcinoma, probably we need to soon forget the radiotherapy. And that's my pitch. And thank you so much for listening to me.
Thank you, sir. And now invite Dr. Madhu Sairam. He's the Director, Academics and Lead Radiation Oncology at GEM Hospital, Coimbatore. Over to you, Madhu.
Good evening, everyone, and thank you, ISO, and especially Samir for giving me this talk. And every time I'm always pitched. I'm sorry, is it moving? Oh, yeah. Every time I'm pitched against a very strong opponent, and this time it is Dr. Raja, one of the most popular medongs in South. But I'll give you a different perspective about the whole squamous cell carcinomas in esophagus. I'll talk about evidence that compares both NACT-RT versus NACT. Also, more importantly, NACT-RT followed by surgery versus surgery alone. Can we convert an NACT-RT into a definitive CT-RT in certain situations? And then what do the guidelines suggest, and some conclusions and inferences. As you can see, among both sexes, generally, esophagus may not be in the top 10 in incidence, but then it definitely features in mortality. So it's a very important cancer. But among males, it features among the top 10, both in terms of incidence and mortality. I'm showing you two data why discussing squamous cell is more relevant to Indian scenario. It's one from Tata, where over 20 years they've not seen a shift in the histological pattern. We still see more squamous cell carcinomas. And then data from Cancer Institute, which also suggests that about 78% of the cancers that we deal with are squamous cell. And mind you all, if locally advanced is relevant because almost 90% of what we see is locally advanced cancer. Coming to the patterns of recurrence, where the difference lies in adenocarcinoma or squamous cell carcinoma. Definitely, the recurrences are much more in adenocarcinoma than in squamous cell. But then the local recurrences are pretty much the same whether it is adeno or squamous cell. The only thing it is different is that the systemic recurrences are actually lesser in squamous cell carcinoma because they respond slightly better to chemoradiation. And then obviously the point of adding more systemic therapy comes and becomes more relevant when it is adenocarcinoma. Well, so let's see if there are any RCTs that compare NACT versus NACT-RT. I do agree that the initial few trials were actually failed trials, which did not show any major benefit when cisplatin 5-FU was used and slightly higher dose of radiation was used, where the toxicity was certainly higher. These are the two major trials that actually did not show a benefit of adding NACT-RT versus NACT. But then we have some successful trials, and two of them that I would want to mention is the NEORES trial, which Sir did mention, a majority of which was squamous cell carcinoma, and the Chinese trial, which exclusively used, which tried only on squamous cell carcinoma. So digging deeper, the 5-year PFS and OS were not different between NACT versus NACT-RT in the NEORES trial, but then the proportion of path complete response were significantly higher, were 9% for the neoadjuvant chemo versus 28% in chemoradiation arm. I've used ChatGPT to actually reformat the tables. Coming on to the Chinese trial, you should understand that even here, the path complete response rates are significantly higher. The overall survival, PFS, and the recurrence the rates are actually much similar. We should also understand one important outcome. Using NACT-RT actually makes R0s better, but then chemo versus NACT-RT did not actually have better R0 resection. So this is another trial which says the path CRs are significantly different with NACT-RT. Coming on to the next trial, which is the Jacob trial, it was slightly different from the other findings, where they found that using a triplet chemotherapy actually had an overall survival benefit over CTRT. But you still will notice that the CTRT arm, even though they used only a doublet chemo of cispa-FU and RT, the PCR rates were actually double in the CTRT arm. So if you are looking at achieving a good good PAT CR, radiation component is very important. Now, let us see the other trials that were discussed. One major thing that we should actually know is that cross has become the standard of care for squamous cell carcinoma, though the component of squamous cells were less. We also noticed that the other study, which is the NEO CRT study, is also there. So looking at the 10-year outcomes of cross, we notice that at a very long-term follow-up, we can notice that adding CTRT as pre-op actually has a 40% reduction in the cause-specific mortality, and there is a significant improvement in the overall survival too. And coming on to the NACRT study, where again same dose, only 40 gray was used, but the chemotherapy was much different, and all cases were squamous cell carcinomas locally advanced. We can notice that the overall survival and the DFS is actually better. So can we, when so many people are achieving path complete response, can we actually avoid surgery or, delay surgery as salvage if they all achieve a good response? I think the data comes one from the JCOG study, where the combination of definitive CRT and a salvage treatment has lower CRT related toxicity and yields a good overall survival. This is one study that actually gave us proof. Coming on to the pre-Sano, which gave us data on how to follow up somebody who has achieved a complete response. This also sets the mood for observation after a complete response after neoadjuvant CTRT. And the proof comes from the Sano trial, where people who achieve complete response to neoadjuvant chemoradiation can actually be put under active surveillance, and a surgery can actually be referred to a later date whenever they recur. And most of the recurrence, if they are followed up, are easily picked up, and the complications are not very different. So this option is also available for those who achieve very good path complete response, clinical complete response. Coming on, I'll skip the meta-analysis and move on to the guidelines. So ASCO guidelines certainly recommends in squamous cell carcinoma definitive CTRT or pre-op chemoradiation, and the recommendation is strong. Coming on to the Japanese guidelines, this is the only guidelines which actually prefers chemotherapy over chemoradiotherapy, and Raja sir actually swiftly moved from this guideline. You should notice that they have actually given both chemotherapy and chemoradiotherapy as the suggestion on the algorithm for esophageal squamous cell carcinoma. Coming on to Chinese guidelines, yes, in fine print, they have actually preferred using concurrent chemoradiation as the chosen option for neoadjuvant therapy. Coming on to ESMO guideline, very clear for all locally advanced squamous cell carcinoma, it is definite CTRT followed by surgery. That is the decision. So let us conclude based on all these trials. You have to achieve a good clinical complete response or a good PCR. You can use CTRT, and we have 4 good trials that suggested. And then if you have to achieve good OSPFS, you have the CROSS in the NACRT trial. And if you have to convert a patient who achieves a CCR into definitive CTRT, we have 2 trials, SANO and the JCOG 0909. And then coming on to pitching the very important point for those who do not achieve path complete response. This checkmate trial is one of the most important trials which gave survival benefit using adjuvant IO in the adjuvant setting. So somebody who receives neoadjuvant chemotherapy, only 60% of them go on to receive adjuvant chemotherapy after surgery, whereas immunotherapy becomes a very easy thing to administer after somebody who does not achieve a path complete response. So using checkmate, if you have done any CTRT, you could still go on and use checkmate 577. So I would certainly prefer NACTRT over NACT. Thanks for the opportunity. Thank you.
Thanks, Madhu. And I now invite Raja sir again for rebuttal. Over to you, sir. So you have 2 more minutes for the rebuttal.
Just hold on for a minute. I will just take out my, I think I'll come straight to the, thank you once again. You would notice that the cross trial is considered as the pillar of strength for the neoadjuvant chemoradiation arm. But you have already heard from me, and he also acknowledged that it had only 23% of patients who had squamous cell carcinomas. And the overall survival advantage of the cross trial was mentioned. But I mean, again, you would notice that it was predominantly, the squamous cell component was predominantly adenocarcinoma, 75% plus. Now, the second question is higher PCR. It is completely agreed that the PAT-CR rates are 20% plus when you add radiation, 28 versus 10 or 11. But the PAT-CR doesn't convert into overall survival. All of the trials that he had noted, the NEORES trial and the JCOG, and all of them showed that the PAT-CR, the overall survival is equal, no different when there was even though there was a PAT-CR advantage with the addition of radiation therapy. Now, coming to the better local control, we see that if surgery is not avoided, better local control can be achieved with surgery alone. And neoadjuvant chemotherapy can achieve all the objectives of the neoadjuvant approach. And some of the NCCN guidelines, ASCO guidelines were all quoted. All of these were Western standards. And I would urge that, as he himself mentioned, squamous cell carcinoma is an important disease. in Indian subcontinent and towards the east. Coming back to the strength of the argument that was presented, all the trials clearly showed that the neoadjuvant chemotherapy and the neoadjuvant chemoradiation were equal in outcome. The point is, what is the complication rate? You would see that the pivotal trial, cross trial, had so much of complication and increased mortality, and the meta-analysis and the other things that I have also presented shows that um, all things being equal, the surgical compatibility and the complications are more with the addition of radiation. So this has to be taken into context when we want to decide between the two. Thank you so much.
Thank you, sir. Madhu, over to you. You have 2 minutes.
Yes. Uh, so the radiation techniques have actually improved, and the surgical complication rates are not different at all in the Chinese trial. And even in the Japanese trial, the surgical complications were not higher. So the more the advanced the techniques are, the complications have actually gone down. That is one point. The other point is Cross has only given us the regimen to experiment. It is not as in we are using the data of Cross. Chinese have proven it, and with exclusively squamous cell carcinoma that CTRT can achieve good PCR, and also there is an opportunity that you can convert those clinical complete responses into observation if they choose to have a salvage surgery. And the other trial is checkmate. If you have to offer the overall survival advantage of using an immunotherapy in a patient, I think using NACTRT would be the best way. People who go through NACT do not have the at least we don't have evidence at this point to continue immunotherapy in them, and they are bound to take chemotherapy after a morbid surgery like total esophageectomy.
If you allow me only one point, which is very important, I think the debate is over, but Madhu and everyone, the whole idea of adding immunotherapy, we have really learned one thing, that the best place for immunotherapy is actually in the neoadjuvant setting. If you look at the lung and if you even look at the esophagus, adjuvant immunotherapy were all there, but now we know that in the head and neck, and even in esophagus and in the OG junction and in entire colon, including rectum, we realize that, and even take breast, bring the immunotherapy up front. That's where the best delivery goes. So leave alone the debate. The neoadjuvant chemoimmunotherapy probably will negate all the advantages of the keynote trial that you presented, and that's the best place. And the advantage is that post surgery or post intervention, once you look at the PAT-CR, you have the opportunity to, or if there's a PAT-CR, you have the opportunity to delete immunotherapy in the adjuvant setting, and the entire thrust of immunotherapy can be brought into the neoadjuvant. Once you bring that, your argument of adjuvant immunotherapy goes away. Nowadays, we are really moving away from that even in the breast, if there is a PAT-CR, we can avoid anywhere. So this is a specific thing that I want to bring here, but otherwise, well appreciated. Thank you so much.
Thank you, sir. So I guess both the debaters have nicely defended the topics given to them, and may now invite Dr. Arvind Krishnamurthy, sir, for the expert comment. Over to you, sir.
Yeah, I think thank you once again. It was a pleasure to hear both Dr. Raja, I think, who I immensely respect, the way he delivers his content. It's really amazing, and of course you hit the nail hard by the immunotherapy sort of what to say, maybe Brahmos rather than the Brahmastra, I must say at this point of time. But yeah, Madhu, also you also had your points, very well balanced debate from both of you all. I thought that I would sort of give some perspectives, because we are talking about squamous cell carcinomas, as was rightly pointed out by both of you all. Because 80% of our esophageal cancers still seem to be squamous cell carcinomas. What we know is that these two cancers are different in many ways. TCGA data sets also says that these cancers have to be treated differently. Initially, we were actually treating both these cancers alike, but thanks to evidences that have been presented, now we are actually understanding that these two cancers are different and we are now treating it differently. Of course, in the modern day, there is overwhelming evidence that both of you all put saying that some form of neoadjuvant therapy has to be given, and upfront surgery is something that has to be condemned in the locally advanced space. And then, of course, it increases PAT-CRs, local recurrences, and improves survival. So we in esophageal cancers, and especially so in squamous cell carcinomas, and also to some extent in adenocarcinomas, what we have found is multiple evidences to suggest that neoadjuvant chemotherapy versus surgery alone, NACT is better. We also had multiple evidences that NACT plus RT versus surgery, NACT and RT is better. And in fact, cross trial was actually comparing NACT, RT versus surgery. And somehow the results were so good that it became a standard of care. So we need to understand these concepts of pathological complete response, R0 rates, overall survival. And as Dr. Raja elegantly pointed out, although in neoadjuvant chemotherapy and radiation therapy, the PAT-CRs are almost doubled. In the cross, we had almost a 49% of PAT-CRs in the subset of esophageal squamous cell carcinomas, whereas about 23% of PAT-CRs in adenocarcinomas. But then it is not that all the PAT-CRs convert into overall survival. So that is something that we need to keep in mind. Yes, with neoadjuvant chemotherapy and radiation, the PAT-CRs improve, R0 resection rates improve, but whether it improves overall survival is the important issue that we are trying to do. Obviously, when we add a modality of treatment like radiation therapy, your complications would be higher as compared to chemotherapy. Of course, you'll have to have fitter patients to undergo this tri-modality sort of a treatment. Again, when it comes to evidences, I didn't really want to sort of present all the evidences, but elegantly presented. In fact, the data in esophageal cancers, the problem in understanding the data is it's so very heterogeneous. A lot of trials actually have combined squamous and adenocarcinomas, the earlier trials. Nowadays, you have a lot of trials, and more so the Asian trial seems to be focusing more on squamous cell carcinomas, especially the Chinese and the Japanese trials, as Dr. Raja said, because the incidence of squamous cancers in the Asian belt seems to be slightly higher. So when we see to head-to-head randomized control trials in only locally advanced squamous cell carcinomas, only, that is, I'm negating all the trials which have actually had a mixed crowd of patients, the trials are just far and few. You have a couple of Chinese trials which showed equivalence, a Chinese multi-central trial, and in fact, they had included an immunotherapy component, as Dr. Raja had said, sintilimab, and in fact, that seems to be one of the standard of care in Chinese. So, and then you had the Japanese, which is always throwing up a googly. In fact, their JCOG NEXT trial, that 1109 trial, as was alluded by both Dr. Raja and Dr. Madhu. Surprisingly, it showed that DCF seems to be the preferred option as compared to sort of, the doublet or the doublet plus radiation therapy. In fact, in India, when I sort of, spoke to multiple oncologists, medical oncologists, they said that administering DCF chemotherapy in the Indian context seems to be a challenge. Although DCF chemotherapy is an accepted standard of care, and especially if you are living in Japan, more often than not, you would get the DCF. But there seems to be some logistical challenges among many oncologists to administer the DCF chemotherapy. And then you have a lot of other meta-analysis, about half a dozen meta-analyses are there. And again, a lot of these meta-analyses have combined. They have adenocarcinomas also. So these are not meta-analyses that are exclusively having the squamous cell cancer locally advanced cohort. And a lot of them seem to actually favor the neoadjuvant chemotherapy and radiation approach, the latest being the Liang's meta-analysis. Again, when it comes to the clinical practice guidelines, and as was alluded to by Dr. Madhu also, and Dr. Raja also briefly said, there seems to be a divide. If you are born in Japan or living in Japan, then you would get DCF as the standard of care. If you are in China, it is likely that you may get a Chinese immunotherapy along with radiation and chemotherapy. But if you are living in any of the Western countries or in Europe, it is likely that you would get neoadjuvant chemotherapy and radiation. Again, as also Dr. Madhu said, that there are other options also beyond these two options also. Definitive CT and RT as the NEEDS trial. This is an ongoing trial which is comparing neoadjuvant chemotherapy and radiation versus definitive CT-RT. Definitely one of the options, especially in unresectable cases, but I guess this debate is more focused on resectable cancers. And also Dr. Madhu also said that the SANO trial, which shows that active surveillance in exceptional responders, again in the context of the clinical trial, and again this seems to be very impressive, the initial data, that is, it is a non-inferior, that is, you do active surveillance also, it's non-inferior, but it is something that you should not practice. But again, as I said, like, you know, Dr. Raja hit the nail, like, you know, the incorporation of immunotherapy, the promising data that was presented in the ASCO last year, and you have multiple trials, at least about 8 trials that are going on at this point of time. You have promising data from the Infinity trials, a couple of checkmate trials, keynote trials, and a lot of Chinese monoclonal antibody trials also are there, which seem to suggest that you have excellent maximum pathological responses. It seems to be a new surrogate endpoint for trials that are incorporating a new immunotherapy in the neoadjuvant space, as Dr. Raja had said. So, and you have better PCRs as well. So my gut feeling is that in the years to come, neoadjuvant chemotherapy and immunotherapy may be a game changer. Of course, we would await robust data from some of these checkmate trials, from some of the keynote trials. Also, there are trials of durvalumab as well in some of these, and the Chinese monoclonal antibodies, and that may sort of, you know, throw open a completely different debate. So I guess in the next version of the debate, possibly next year, we may have a debate of neoadjuvant chemo-immuno versus possibly neoadjuvant chemo or neoadjuvant radiation or something like that. I think that seems to be the trend to go. But I must conclude that, of course, the guidelines are different in depending on where you are born or where you are there. But one must understand the trimodality treatment is actually a toxic treatment to an extent. So case selection has to be very, very crucial. In fact, of course, we've also learned it the hard way that, of course, we have been, and I think many centers around India also have been given trimodality treatment and successfully operating on all these patients. But again, case selection is very, very crucial. You must have some knowledge about what your expertise is. And it is always best that such decisions on case selections be taken in the context of a multidisciplinary trial. And I'm sure that, you know, Sabita in her next version uh, of her case series will sort of you know, bring about some of the ideal cases that are suited for a multidisciplinary. On and all, I enjoyed the presentations of both Dr. Raja and Dr. Madhu. Dr. Raja, also you gave an Indian context to it. Also, it's something that we really very appreciate, and I think the over 200 odd people who are there in the audience would have thoroughly enjoyed this. And back to you, Samir.
Dr. Arvind, I have a question. I think the debate is over, so we can be, you know, Madhu, I mean, you know, Madhu did very well. The debate is over. I want to ask a question because we talk about post-CTRT surgery, even in the best of the centers, where we have all the, you know, minimally invasive techniques, and by default, minimally invasive surgeries have come into vogue in some of the tertiary centers, including yourself. There is a real challenge in, you know, going ahead and surgery and post-op. So what is your
Raja, let me hold you there because we have an interesting debate by Dr. Sabita, and I'm sure she'll be covering these issues in her panel. And we also have one more stalwart to give the expert comments at the end of the panel discussion. Dr. Subramanyeshwar Rao is there, and so I think over to you, Dr. Sabita, to conduct the panel.
Thank you, sir. So excellent debate. I enjoyed both the presentations, and now we'll move on to our
Raja and Madhu, you can hold on till the end of the meeting.
Yeah.
So I'm sure we'll have a great question answer session. We
Yes,
have
sir.
some questions on the screen, but I think you can, Sabita, can take up whenever you feel appropriate.
Yeah, any of the faculty, please feel free to answer the questions. I'll get started with the presentation. Neera, can I share my screen?
Yes, madam.
Yeah. So, we'll be talking about some controversies in the management of esophageal cancer. And like the previous speakers have pointed out, squamous carcinoma is really our disease. So I will be sticking to that histology because GE junction and adenocarcinoma becomes a totally different chapter. And I think we'll cover it in our future webinars later on. So our panelists are Dr. Sayan Paul, Dr. Bharti Devnani, two radiation oncologists, two surgical oncologists, Devendra and Caleb, and two medical oncologists, Dr. Krupa Shankar and Dr. Niti. So welcome to all of you. And this is our 8th webinar in the Indian Society of Oncology, a truly multidisciplinary society where we try to involve everyone and choose topics where everyone can learn and teach and share their beliefs and give their expert opinions. So starting with the case discussion, our patient is a 63-year-old tobacco chewer who was a hypertensive, and he had a history of cholecystectomy as well as spine surgery. He came to us with grade 2 dysphagia, no significant weight loss, and an endoscopy, which was done outside. So the cricopharynx was at 15 centimeters. He had a growth in the middle third of the esophagus, and the scopy could not be completed. So coming to the surgeons, Dr. Caleb and Dr. Devendra, do you often see reports like this where the scopy is not complete?
Yeah, quite often. So
Yeah,
some,
yeah, go ahead, go ahead.
yeah, this is very common because many times we see patients with grade 3 or grade 4 dysphagia, and the main crux is to ensure the nutrition of the patient is established. So that is the main concern. We either have to pass a nasogastric tube or feeding jejunostomy, which has to be done. So.
Yeah, so whenever we see a patient like this, we always ask them what the grade of dysphagia is. And if they are able to take liquids and, adequate liquids, 1.5 to 2 liters in a day, where they can maintain their nutrition, hydration, we can supplement with protein supplements, then we will not think of putting a nasojejunal or a nasogastric tube. But anything more than that definitely deserves nutritional rehabilitation, like Dr. Caleb pointed out. So this was what the endoscopy looked like, but the patient said he had only grade 2 dysphagia. So we decided to stage this patient because he was otherwise quite fit. So coming to the staging investigations, Dr. Devendra, do you always ask for a PET CT, or is your first investigation of choice a CECT?
Endoscopic biopsy is confirming malignancy, then PET CT will be my preferred investigation.
Yeah, it was a moderately differentiated squamous carcinoma.
Yes. Then
So,
PET CT has to be offered to the patient as
okay.
a first metastatic workup.
Anyone has any difference of opinion? Dr. Bharti, Dr. Sayan, Dr. Niti?
But I also prefer, ma'am, PET CT scan for staging because sometimes some lymph node can be picked up and some split lesions also can be picked up.
So that's what we also did. We did a PET CECT, combining both the investigations in one go. And this is what it showed. So it was a middle third tumor starting just above the level of carina, small periesophageal and paraesophageal lymph nodes, which did not have much uptake, and pulmonary parenchyma on the lung window was normal. So this is what the PET scan showed. And along with this, would you like to do any other investigations? Dr. Kripa Shankar or Dr. Devendra?
It's free from the bronchus.
Yeah, if you want, we
Even
can.
though we say bronchoscopy in all supracarinal regions, but in such situation, we may avoid bronchoscopy and start with the neoadjuvant strategy.
Caleb, would you do a bronchoscopy?
Yeah, I usually see the CT scan, and if I feel that the tumor is abutting the trachea and more importantly the left bronchus, then I'll usually get a bronchoscopy done.
So in this scan, at least the planes were very well maintained. but it was a little bit of supracarinal at the level of carina. So I think if we think the planes are okay, we can avoid a bronchoscopy. Anybody would do an endoscopic ultrasound?
If the scope was negotiable, then yes, endoscopic ultrasound to at least look for the T status.
So for all cases, would you prefer an endoscopic ultrasound?
I mean, wherever feasible, yes.
Okay, okay. Anyone else would beg to differ?
Yeah, I think such a locally advanced case, it may not be of much. I mean, it won't change the management much. Whereas in an early, maybe T1, T2, when there is just a thickening of the esophagus, probably we should go for an endo ultrasound.
I agree with Dr. Caleb. If we are contemplating upfront surgery, only in such situation we confirm our T and N stage with EUS.
And Dr. Bharti, if this patient came to you?
No, we do only in early cases because PET CT and endoscopy is sufficient, I think, in this locally advanced case.
Dr. Sayan, any opinion?
So we will also do only PET CT and endoscopy because this is a bit advanced disease. I won't go for endoscopic ultrasound. But yes, cardiac evaluation and PFT, all others are needed because we need to assess the operability of this case beforehand, before you jump into neoadjuvant therapy.
So we discussed this patient in our MDT, and we thought it was slightly locally advanced because you could see the thickening of the esophagus. There were some periesophageal, paraesophageal lymph nodes. So, but the planes were very well maintained. So any takers for upfront surgery? Anyone would prefer or think of upfront surgery in this case? Nobody's answering me. So what would the neoadjuvant strategy be, since we are all wiser after the debate?
As a surgeon, I'll be more happy to give my patient neoadjuvant chemoradiotherapy when squamous cell carcinoma is the etiology.
Okay. So one person for NACT-RT. Anybody for NACT only?
I think
I will also go for NACT-RT because this is an ideal case for NACT-RT for cross protocol.
Okay.
And especially if there is obstruction, the radiation will relieve the obstruction and will help in the dysphagia also during the RT. So in this patient,
Okay. Anyone wants to give only NACT? Dr. Neeti?
I'll go with neoadjuvant chemoradiation in this patient.
So I guess everyone is in the favor of neoadjuvant chemoradiation. Caleb, any points to make?
Yeah, I think this is the only patient, one of the few patients who actually will fit into the cross criteria actually. So because this point was not discussed much because it's important to stress that cross was only up to T2, T3 and N1. So most of the patients we see in general are unlike this with T4 tumors, I think. So this patient is an ideal fit for NACT-RT.
Actually, even the median length of the tumor in cross was 4 centimeters, and this is quite a short length tumor. So again, it would fit into that criteria. Any indication where any of you would think that you would prefer NACT, if anything was different in this scan?
So probably the fat planes were probably abated, and if it was involving the trachea or on a bronchoscopy did show involvement, then I'd probably be tempted to do neoadjuvant alone, chemotherapy alone, and then follow it up with radiation. I think T4 I would really do.
Yeah, I agree. A T4B lesion would definitely be an indication for neoadjuvant chemo alone.
Yeah, any risk of, any impending tracheoesophageal fistula also is there, then will not do radiation, will go for chemotherapy.
I think one more thing indication would be when we have a mid-third tumor with celiac nodes. So, nodes in the around the left gastric, that will be again an indication for a chemotherapy rather than a radiotherapy.
Right. So if you have any nodes which are far away from the point where you're planning to give your neoadjuvant chemoradiation, suppose you have a supraclavicular lymph node or you have a gastrohepatic lymph node, then I think it becomes difficult for the radiation oncologist to encompass so much, starting from the neck, going down to the abdomen. So point well taken, Caleb. That is one of the indications where we would go for neoadjuvant chemotherapy only. But with the next data coming in, is anyone tempted to give triple drug regimen because this patient seems to be fit?
Yeah, I'll be happy if our colleagues give, but many times DCF is a problem. One is even logistically admitting the patient, and patient tolerance is also a problem. Apart from that, I'll be happy if they can.
Yeah, so we have a trial running at Tata Memorial Hospital right now, where we are enrolling patients for neoadjuvant chemotherapy versus triple drug regimen versus neoadjuvant chemo radiation. We've just started accruing, and the patients seem to be tolerating DCF quite well. But like Dr. Raja and Dr. Madhu pointed out, we need to select the patients well. So going on to the next slide. This patient did receive neoadjuvant chemo radiation, the cross protocol, and completed it in February. And this was the scan which was done. So just a question to the radiation oncologist, when would you send the patient for a scan after completion of neoadjuvant chemo radiation?
Yeah, if the patient is already planned for surgery, I mean, then we'll do it after 6 to 8 weeks time, around 6 weeks time. And if we find that complete response, then maybe we can just wait and do a scan after 3 months. But usually it is 6 weeks time when we send to the surgeon.
Anybody else has any other time interval for doing a response assessment?
Ma'am, there's a small data on PET-directed alteration of therapy. So in which early assessment at 4 weeks is recommended, in which if there is a residual disease, you may actually think of adding more therapy in the form of chemotherapy. And what was not given in the past. So if in cross trial you have used Paclitaxel, you may try to switch to Folfox and then do surgery eventually. So there is a lot of, data now about PET-directed therapy. But if we know that the scan has good response, we would at least wait for 6 weeks to plan a surgery.
Okay, great. So we usually do a scan at 4 weeks, and I don't think we add more therapy. We just see what the response looks like. We don't want to wait too long. So anywhere between 4 to 6 weeks is acceptable actually. And this is what the scan showed. There was good metabolic as well as morphological response in this tumor. And the patient tolerated the neoadjuvant cross protocol very well. So this is one of the reasons why this protocol has become so popular, because generally the dose of radiation which is employed as well as the chemotherapy regimen and the dosage is quite well tolerated, did not have any significant toxicity, had resolution of dysphagia and no weight loss. So for response assessment, does anyone use only CECT or is everyone using PET? Dr. Bharti?
We are using the same modality as baseline. So in baseline, we use PET. So for response assessment, also we use the PET scan.
Yes,
PET
Dr.
CCT.
Okay, great. Dr. Krupa Shankar?
Yeah, I think I would probably just stick to, if it's localized disease, I think I'd probably prefer just CCT alone.
CCT.
I wouldn't probably look at getting a PET for one salary.
Anyone does anything different? And at what interval? I think we spoke about that. That was at 4 to 6 weeks, but not later than that. Anyone will do a repeat endoscopy if the initial endoscopy was incomplete? Caleb?
Yeah, we routinely do a repeat endoscopy after the neoadjuvant therapy.
Even for squamous?
Yeah, we just tend to do.
Okay.
Yeah, we also do a repeat endoscopy at response assessment.
But if the patient is saying that he's eating everything, the fusion images on PET CT are showing you a localized disease, do you think it is worthwhile repeating the endoscopy?
I do know, but it's just as a routine we do it. We don't look into it because sometimes many of these patients don't get an initial assessment. So it will be good to see the, up to the stomach, just to have to know the status of the stomach prior to the surgery.
Dr. Devendra?
At our center, we usually don't do repeat endoscopy if you are planning surgery. But as this patient may have incomplete endoscopy at the time of first evaluation, we may think of endoscopy, but that will not be a separate procedure. It will be at the time of surgery only.
Yeah, so actually there's no definite evidence and it is institutional based practice. So if we go by clinical indications and by the PET, if the patient has good resolution of dysphagia, symptomatic relief, and the PET is showing a good response, then usually we avoid the endoscopy, especially in a squamous, because the PET fusion images actually correlate very well with the extent of disease. But if we have any doubts regarding a skip lesion, or if the patient's dysphagia is not resolved, or the PET is showing some other finding, then we would repeat the endoscopy. So functional evaluation we already did before we started the neoadjuvant chemoradiation. So to Dr. Bharti, I would like to ask you, do you do a pulmonary function evaluation before giving neoadjuvant radiation, or are you just happy with the routine investigations?
We generally do pulmonary function test evaluation before chemoradiation.
Okay.
But if surgeon is like willing for surgery, then the patient is mostly fit for radiation also.
Wow, you have a lot of confidence in us. So do you repeat this pulmonary function evaluation after giving the neoadjuvant chemoradiation?
No, except in cases where the patient has some symptoms of pneumonitis or something. If the patient is very symptomatic and improving, then we don't repeat.
Anyone else who does not repeat the functional evaluation? Caleb, Devendra, Dr. Kripa Shankar.
Usually we don't repeat unless if the patient is not doing well, but generally the patients come back better after the NACTRT. So
Yeah, unless and until they've had some pneumonitis or they have some symptoms like a cough or a fever. But usually our radiation oncologists will usually repeat the functional evaluation. They want to see if there's been any change in the PFT, especially in a middle third. So they usually repeat the PFTs and see how it's going. Dr. Sayan, any comments to make?
Yeah, we need to do these assessments before starting NACTRT like PFT, because suppose the patient is medically inoperable, and then we may need to change the cross protocol. We may need to use the definitive chemoradiation rather than using a cross protocol. So I'll always do before starting NACTRT, and after the completion of treatment is actually depends on the surgeon's preference. If the surgeon is asking for a repeat PFT, then we do not prescribe. We just depend on our surgeons. If they want, then they do it before the surgery.
Dr. Neeti, any experience with giving neoadjuvant chemo immuno to squamous esophageal carcinoma?
Ma'am, in this kind of a stage, no.
Okay. So in what indications have you tried it?
If they are unresectable, then that's probably one area where I would explore chemo plus immunotherapy.
So I think we are still awaiting some concrete and level 1 evidence to actually employ it in the neoadjuvant setting as a routine. And I think the time will come in the next 1 or 2 years. So, so far it is so far chemo and immunotherapy is indicated only in a very advanced and borderline resectable or non-resectable cases. So to the radiation oncologists and surgeons, when do you think we should plan the surgery after NACTRT? And we have some papers on this. So any preferences?
As a surgeon, yes, please, Kalam.
we tend to do between 6 to 8 weeks.
Same. Same is our preference.
Why not at 4 to 6 weeks?
We usually, madam, call the patient for evaluation between 4 to 6 weeks, and usually our patient take another 7 to 10 days. So usually between 6 to 8 weeks is the time where our patient goes to actual surgery.
So there is some data where they say that the response continues to evolve till 6 weeks. So that is why the radiation oncologists want us to wait till at least 6 weeks, because there is some data that they may have a more response if you wait till 6 weeks. And Caleb, back to you. Why not after 8 weeks?
The longer we wait, probably there is fear of increase in the fibrosis. And I've had this when patients have come delayed or due to certain reasons, wait list, and patients have delayed and we've ended up having dense fibrosis. So that is why we tend to do finish before 8 weeks.
Anyone, any evidence? If we delay surgery, what happens?
Yeah, this is actually a good question. I need also inputs from the surgeons, because I have seen some surgeons, they are preferring 8 weeks. They are preferring to wait more than 6 weeks. So if it is really a problem operating, that I want to get the feedback from the surgeons.
So as a surgeon, our preference is 6 to 8 weeks. But if patient come after 8 weeks, and let's say 10 week, 12 week, there is no hesitancy in terms of offering surgery. Yes, I agree. Radiation-induced fibrosis will be somewhat more than what we see when patients are between 6 to 8 weeks, but that's not a big problem at the time of surgery. And another thing, as Madam said, that with increasing time, response rate increases. But as a surgeon, we don't aim for PET-CR. We aim for R0 resection. And if scan is showing good response to neoadjuvant treatment, and we are confident about R0 resection, then that's the time we hit the patient with surgery. That is 6 to 8 weeks. So we are fine with any patient who is coming after 8 weeks, but our preference is 6 to 8 weeks.
Yeah, very well put across, Devendra. Our aim is to get a R0 and we are not actually hunting for the PAT-CR. Also, there is evidence to show that if you delay surgery to beyond 10 weeks, the outcomes are worse in terms of complications. So these patients tend to do worse in terms of anastomotic leaks, in terms of pulmonary complications, if you wait for more than 10 weeks. So ideal time is anywhere between 4 to 8 weeks. Most people prefer between 6 to 8 weeks. So we evaluated this patient for surgery at 4 weeks. That is when we start working up the patient. So if there is anything that is correctable, that can be done in the time period that we have of 2 weeks. So this patient was actually quite fit when we first looked at him. And then we sent him for an anesthesia checkup. And this is what they found. This patient had a persistent high APTT, low platelet count. They were not so low that any neoadjuvant chemoradiation could not be administered. And if someone looks back to the first slide that I said, at that point also the INR was deranged. So this is what we found. So to the radiation oncologist and medical oncologist, what are the toxicities that we usually see with neoadjuvant chemoradiation? Bharti, can you start first?
Yeah, so mostly the counts, in this case, I think we should assess the other cause also for low platelet count. And the most common toxicity sometimes is like a cough and pneumonitis, but the dose 41.4 is so less that slowly with improved techniques, we are seeing less toxicities in these patients. And mostly it is well tolerated. But yes, with some blood count, the decrease in counts, and in few patients who have poor GC and the nutrition is not adequate, the symptoms of pneumonitis appears, fever and cough.
Dr. Paul, anything to add?
Yes, because in esophagus radiation and that too with cross protocol, we treat very less bone marrow. Bone marrow suppression with radiation is very unlikely in cross protocol. And if you are doing IMRT technique, not that you are treating a lot of bone marrow. So only these things, esophagitis is the main thing that is fine. Pneumonitis, transient, I don't see much pneumonitis in cross protocol also. So it's mostly esophagitis, and then also if the obstructive symptoms get relieved, then symptomatically sometimes it is not that bad, like when we treat other cancers and we get esophagitis. So when I treat esophagus, it is a little easier than treating other cases when the esophagus gets significant doses. So bone marrow depression, I don't think is a very common complication for
This
cross
patient
protocol.
actually didn't have bone marrow depression. Everything else was normal except the coagulation parameters. We did an ultrasound of the liver. We got the medical gastroenterologist involved, the liver clinic involved, and finally we referred him to a hematologist. So the
So,
hematologist.
ma'am, there was a coagulopathy which was not noticed because baseline also APTT was high.
Yes. So this was the problem. And then the hematologist told us actually to do a bundle of investigations. And this is what they found. The D dimer was high, fibrinogen, reduced levels of vitamin K and related factors. The lupus anticoagulant was positive. We also did a TEG, which was deranged. So after much debate, we decided to take this patient back to MDT. And already it was 4 weeks past giving neoadjuvant chemoradiation. So the only way forward was to make this patient fit for surgery. So we went ahead and by the time it was 6 weeks, when all these references were done and all the investigations are done, we gave him vitamin K, we gave him FFP, but nothing changed. He's continued to have persistent deranged coagulation profile. And the hematologist told us that he has high risk of hemorrhage and a 5% risk of life-threatening irreversible coagulopathy. And he is likely to require a lot of blood and blood products intra and post-operatively. So now we've come to the golden period where we should be operating, but this patient is high risk. So these are the options that the patient has. Surgery with high risk consent. And when we saw the scan, It looked pretty good. There was good morphological and metabolic response. The SUV had decreased from 9 to 3. It was not 0, but so there was another option of waiting and watching or active surveillance as SANO. So coming to the radiation oncologist first, do you think SANO is ready for prime time in the Indian context in this setting, in this patient?
Yes, I feel that this is an ideal case for watch and wait protocol. And that's why I always feel that cross protocol, though they have used a little lesser dose, and usually we use 50 gray radiation to esophagus as definitive dose. So feel that if if someone does a study with 50 gray as neoadjuvant setting, we might get more clinical complete response. And these situations will be beneficial when surgery is not possible. We may watch and wait those patients. So that is a thing, but cross protocol is only a little lesser dose than 50 gray that we use. But with that also, watch and wait protocol will be a good protocol for these patients.
Coming to Dr. Bharti. Bharti, any cons of doing the wait and watch, active surveillance?
So I also want to add for this patient, if this would have been investigated thoroughly at the baseline, I think we would go with 50.4 higher dose of radiation. So,
So that was not done. Now you missed
lesson
it.
learned.
I sent the patient to you and you missed it. You gave
Yeah.
adjuvant chemoradiation.
So yes, in our setup, I don't think we are ready for Sano because so many active surveillance we have to do biopsies, and patient generally lost to follow up. Even after surgery, they sometimes don't come for follow up. So for Sano, a patient who is motivated for active surveillance, only in those patients, I think we should go. But in this case, if surgery is not possible, I think that is the option remaining. But no, we are at least at my institute, we are not prepared for SAM.
Dr. Kripa Shankar, surgery or Sano?
I think in this scenario is more like a forced wait and watch policy, so like a forced Sano here. But otherwise, I think in general, if the patient was fit for surgery, I'm sure most of us would have taken this patient up for surgery. But given the circumstances here, maybe Sano is not such a bad approach here, given that the patient is not fit for surgery.
Caleb, what would you do?
Yeah, I think for this patient, Sano is probably the better way of considering the risk. But I think I don't think we are ready for widespread adoption of Sano, because first of all, our gastroenterologists have to be they have to get accustomed to this sort of surveillance, the bite on bite biopsies and the regular follow-ups, those things, and endo ultrasound. I mean, I don't think not everywhere endo ultrasound is widely available and with the expertise also. So I think it's too early to say Sano here. And again, we have to remember that even the Dutch group also, they did a pre-Sano trial just for people to get accustomed to these protocols. So it's too early for us to accept Sano.
So Sano threw some really, astounding results.
Can I just say something? Sorry. This is a case in which we were forced to not do anything. I mean, wait and watch. But in this case, would you write something like capecitabine or even a nivolumab, assuming that there was a residual disease not seen in scan and which we don't know?
Yes.
Or we did an endoscopy and found out that there's a residual disease. In that case, obviously, we would have gone for resection. But here we are assuming that there's a residual disease, which we have not proven. Would we continue something?
Yeah, so we'll come to that, and we'll just discuss the Sano trial, and then we'll come to that, what the patient's options are. So what the Sano showed us was that even though numerically the disease-free survival was better in the surgical arm, and the median OS in the modified intention to treat analysis was better in the surgical arm, the overall survival at 2 years actually was 3% better in the active surveillance arm, and they had a non-inferiority margin of 15%. So they managed to show that active surveillance was not inferior to surgery, and in fact, it was 3% better. But mind you, these are only 2-year results, and this is not the actual follow-up because the trial is designed for 5 years. But this trial had a lot of problems, and personally, I have spoken to the principal investigators of this study, and they also acknowledge that there was a lot which was muddled up in this trial. So it was 15% non-inferiority for a aggressive disease like squamous cell esophageal carcinoma. I think this margin is too much to accept. And also the pre-Sano patients, which were used as the, the group where they practiced on, 35 of those were added. And this was a cluster wedge step randomized design. So they could add and subtract patients. Like somebody pointed out 6 weekly endoscopies. I think Dr. Bharti pointed out bite-on-bite biopsies. Caleb also said that they are not trained that much. Also, what this trial had, that when you got a biopsy which was suspicious or showed dysplasia, there was a central pathology review by expert pathologists which dealt only with esophageal cancer. If any patient had dysplasia or the endoscopy was not complete, these patients automatically went for esophagectomy. And like the cross trial, more than 70% in both the arms were adeno-CA. So only 25% of the patients were actually squamous carcinoma, which is the disease which is more supposed to be more chemo radiation sensitive. Again, when you come to the active surveillance arm, 35% only maintained complete CR, 48% developed local recurrence, and a lot many developed distant metastasis. Distant metastasis was seen in complete clinical responders. All those non-complete responders who were operated after 10 weeks had worse outcomes. And even though the quality of life was better in the surveillance arm till 10 months, after 12 months, there was no difference. So I have a lot of problems with adopting this study to our population. And I really think if we are taking this, it has to be taken as the pinch of salt. And like all of you mentioned, if we are forced to adopt the wait and watch when the patient is high risk for surgery. So we counsel the patient for surgery. This is the risk and this is the alternative option. So patient was not willing for high risk surgery. And like Dr. Niti said, we did an endoscopy which showed nodular mucosa, no definite growth, and the endoscopy could be completed. Now the biopsy showed severe dysplasia, cannot rule out invasive component. And like I told you, the PET-CT had shown a SUV max reduction from 9 to 3. So now you're suspecting that this patient is not a complete responder and there is a component or a small focus of disease which is there. So what next? Would you counsel for surgery again? Because now obviously completing radiation is out of the window. So coming back to Dr. Niti, would you be able to offer something to this patient?
If the patient is ready for surgery, I'll get in touch with the hematologist and try to take up for surgery. Otherwise, as I was saying, I'll definitely at least put on some kind of therapy.
So some kind of therapy, what would work in such a case or in any high risk case where, we are faced, if the general condition goes down or the patient develops a complication with neoadjuvant chemoradiation, what works? What kind of systemic?
I mean, at least a single agent therapy is what I will continue.
So we consider the patient from a curative setting, the patient becomes literally palliative because we know that a single agent will not be curative in this setting.
So my focus will be try to see if I can actually convince the patient for surgery. And obviously, I mean, around perisurgical time, there would be solutions.
Right. So Devendra has raised his hand. Yes, Devendra, please go ahead.
We had such instances, and usually we reserve the FFP for surgery, and we actually counseled the patient for surgery, and we went ahead. We had taken a special consent of abandoning the surgery if there is a unusual bleeding, unanticipated bleeding in the beginning of the surgery itself. But to our surprise, the surgery went very well, very smooth, and patient recovered nicely. So in such situation, I'll be aggressively opt for or counsel for the surgery.
So I think we are not doing so well with the time. So now these questions are only for the surgeons. So one by one, please go on answering. So is surgery different at 6 weeks versus 12 weeks now? Because 3 months are over in all this workup. So after neoadjuvant chemoradiation, both of you, do you think surgery is different at 6 weeks versus 12 weeks?
It will be the same.
Caleb?
It depends. It depends on patients, sir, because sometimes even today I was expecting a bad fibrosis, but then it didn't seem so. So it depends on each individual, I think.
Yeah, so I think it depends also on the location of the tumor and how it was pre-operatively. If your planes were great to begin with, then we don't see much of a problem. But if the planes are slightly, indistinct, or it has been borderline, we expect fibrosis, especially in middle thirds. Lower thirds, actually, there is no difference in the surgical complications or the level of difficulty. So surgical approach, open, minimally invasive, VATS, robotic, any preferences?
For middle third, my preference will be RATS, robotic assisted surgery.
Robotic.
That's
VATS.
yeah.
Anyone else open? Nobody. I think everyone wants to do MIS. Extent of lymphadenectomy?
At least total mediastinal lymph node. If not mixed, but bilateral supremediastinal. So proper supremediastinal node has to be addressed in such setting.
Even though the PET did not show any superior mediastinal lymph nodes, you would still address them?
Yes, madam. For a 60-year male with good performance status, if everything is, this is the time we actually cure the patient with our aggressive surgery. So I'll be very aggressive in doing node dissection in especially middle third esophagus.
Caleb, any difference of
I'm also doing total mediastinal. We used to do only infracarinal, but then ended up the patients came back within a few months with supracarinal nodes. So
anyone using ICG routinely in such cases after neoadjuvant chemoradiation, operating after 12 weeks?
So in all our esophageal cases, we do use ICG, but not for mapping of the lymph nodes. We use the ICG for different purposes, like to define the thoracic ducta or to see the vascularity of the conduit, like that.
And regarding the anastomosis, are you happy with a stapled or would you prefer hand sewn?
Many a times for upper or mid thoracic esophagus, doing stapled anastomosis is difficult because of shorter length of cervical esophagus. But if there is a cervical esophagus long enough to do stapled anastomosis, I'll be certainly go for stapled anastomosis.
So actually you have to get a 5 centimeter margin and you have to see where that thickening is. So if you are getting a good margin, yes, go ahead with staple, but sometimes you are forced to do hand sewn. So the patient underwent surgery under FFP cover. It was a oozy field, but no massive blood loss, just like Devendra had. And the post-op course was as expected. But suddenly on post-op day 5, this patient started giving us trouble. He had high-grade fever, multiple spikes, tachycardia, tachypnea. X-ray chest showed a effusion. Drain was okay. Neck wound was supple. Counts were slightly raised. Creatinine was slightly raised. So we did a scan. And this is what the scan showed. So Caleb, any thoughts on this scan? I'm not playing the video.
Is there a video, Sabita?
No. I don't have a video.
So there is a leak, or is it into? I think it's
there is contrast. I pointed a blue arrow to that.
Yeah, there's a contrast, so we'll have to drain the collection then.
So what is your preferred method of managing this complication?
So usually we do a guided pigtail insertion, either ultrasound guided or a CT guided, and then antibiotics and wait and watch. Because cervical anastomosis, it's not easy to put a endosponge or other things. So
anyone would do an endoscopy, and what are the indications of doing an endoscopy in such a case? Devendra? Anyone else? Is Dr. Kripa Shankar still there?
Yeah, I'm still here.
Yeah.
So only indication of endoscopy, the patient is not. Yes. So as Caleb said, we need to drain the collection. That has to be a first step. We also need to upgrade the antibiotics and our conservative management. But with that effort, that is the time we do endoscopy to see the vascularity of the conduit. Am I audible?
Yeah. If the patient is not doing well, if the patient goes on inotropes or goes on ventilator and clinically, yeah, you're better now. And
yes. So
anyone would want to explore this patient with this scan? No,
I think we can try a
so what we did was actually we did a endoscopy because the leak was quite large and the drain. Yeah, conservative. Yes, conservative. So we saw a cavity and we put an endovac sponge and we applied negative suction. So, but a lot of things could go wrong. Your stomach tube could look like this or like this, or you could see something like this. And these are the complications chemoradiation and your operation. fibrosis. There is some decreased blood supply to the air orals after 1 month, and this is what pathology showed. Small focus, but 3 lymph nodes positive, and this was in the abdomen, left gastric lymph nodes, and otherwise margin, CRM, everything was free. So coming to Dr. Niti. Niti, would you like to offer this patient?
Sorry, ma'am, what was the question?
Anyone would refer this patient? I said, with this histopathology, do you think this patient needs any adjuvant?
Yeah, with the checkmate result, adjuvant, yes. Do you routinely do tumor regression score as well, ma'am?
Yes, we do. The tumor regression score in this patient was 2/5.
Right, right. No, and we'll definitely give adjuvant. I mean, initially 2 weekly and then later on 4 weekly for a total period of 1 year.
Okay. I would like to ask the surgeons, the adjuvant trial so far has shown only DFS benefit, and this patient has had a stormy post-op. So would you like to send this patient for adjuvant chemoimmuno? And that's my last question.
We tend to counsel the patient, but tell them if you don't have money, don't lose sweat over it.
Any of the other surgeons, any other opinion?
I agree with what Dr. Caleb says.
Great.
Right.
So thank you so much, everyone, for a wonderful interactive panel and bearing with me and my questions. So I'll hand it over to Dr. Sumant. We are done with the panel. I won't go on to the next case because we are already running short of time. Thank you, everyone.
Samir said you take over. I think Dr. Sumant is not here.
Yeah, Samir, please.
I think great panel discussion by Sabita. You engaged all the panelists so well. And I would invite Dr. Subramanyeshwar Rao to give your expert comments and your words of wisdom. Share your experience.
Thank you very much, Rajendra. Rajendra, dear friend for a long time. Thanks for having me here. Thank you, Arvind, Sabita, Samir, Sumant, all of you for inviting me and forcing me to listen to the whole session. I don't do this too often, but if you are asked to give the concluding remarks, I think you have booked me for the entire session. Especially Rajendra knows all this. So anyway, thank you very much for having me. I really enjoyed the session because it has been truly multidisciplinary. Real experts have been invited from and equal proportion. I think justice has been done to all the 3 major treatment specialties of cancer. I think really I enjoyed Raja's and Madhu's debate. Raja is a seasoned speaker, and Madhu actually matched him very well. And Arvind, of course, is known to everybody. And the only complaint I would have had is the whole debate and the expert, all 3 hail from one state in the country. Otherwise, I think it was immaculate. And then Sabita, of course. Sabita is easily one of the best moderators across all specialities. And within oncology spectrum, I think every event has a session where she moderates. So she's so skilled in it. So she does it well each time and every time. And the participants were really good. They were so informative. Niti, Sayan, Bharti, Devendra, Caleb, Krupashankar, all of you have been superb and on the dot. You didn't waste time. Yeah, and you didn't beat around the bush. You were not dishonest at all. You expressed everything that you do on a daily basis. That's what you need in these sessions. It's much beyond learning because it would influence the next patient's treatment on the next day itself across the country. Over 200 people are listening to you, so I think you have a responsibility, and you all have done a great job. I have nothing much to add to what has been told already. Truly enjoyed the talk, and I would promise that I'll start attending ISO sessions in future because I like the module and the way it's done. Thank you very much. Thank you.
Dr. Rao, would you want to share your experience about treating esophageal
No,
cancer?
all of them know what we do.
Any
So,
tips and tricks to share with the youngsters?
I don't know. In each situation, I would have had something to say, but I think it would become a very, very, very long talk or a very long discussion. In each situation, starting from the debate, I would have had a few things to say. But I think it was done so well, you would not need my wisdom at this stage. Anything specific, Sabita, that you would want me to opine? I'm cool. There's no problem.
No, sir.
Yeah.
Sir, in such a patient with a bleeding diathesis, what would you have done, sir?
I would have honestly taken a chance and operated. And whenever we have done that, we have come out trumps. There's no problem at all. See, all this, I mean, much worse coagulation problems, we did these procedures. As long as you do it with the gentle hands, the body supports. I would have operated on this patient. That's probably one of those differences. And I would not have followed Sano. As long as the patient surrenders to me and accepts everything, I'm very aggressive. I do everything then and not wait.
Yeah.
I'm one extreme, but it works. It does work.
That was my question, sir. Would you have ever followed Sanu?
Yeah. No, I would not have.
So thank you everyone for joining us today. It was a wonderful session and great participation from everyone. Our next webinar will be on 18 June. That's the third Wednesday at 7:30 p.m. on pancreatic cancer. We'll come up with some more controversies and debates. So looking forward to see you all there. Thank you.
Thank you. Thank you, all of you.
Thank you.
Thank you, everyone. Good night.
Thank you. Good night.